I'm Ravi Karkar. I'm a postdoc here at UW in CSE, working with James Fogarty and Gary Shea in HCDE. And I got my PhD in CSE from UW itself. And I think the way I'm situating this talk is essentially providing motivation for us to think of alternate approaches to analyzing and collecting the data for health-related tracking. So traditionally, most of the research that we have done, at least in our group and others that we have seen, is mostly using basic correlation analysis or frequentist statistics to answer the data that we are collecting. And in this paper, we argue for more sort of HCI research as looking at Bayesian alternatives towards better communicating those kind of analysis. And this work was done in collaboration with Jessica Schroeder, who's on the call, James Fogarty, also on the call, Julie Keen, Sean Munchen on the call, and Matt Kay, who's not on the call. And I want to put it out there that I'm not the statistical expert here, and I won't be focusing on that bit. It's mainly about motivating why we need that. So with that, the talk is briefly sort of basically organized into three sections. The first is what are the types of questions that people want to answer using their own health data? And what are the capabilities of different statistical methods in answering those questions? And what are the design implications for people who are sort of going to build tools in this space? So with that, I had used the word self-experimentation in the previous slides, and I recognize that some people might not be familiar with it. So I just want to take a brief moment to explain what I mean by that. So we have seen a surge of more affordable sensors, trackers, and applications which help people in collecting more and more health data about themselves. And what we have noticed this leads to is that people are trying to experiment on their own to figure out how different behaviors or different activities or different aspects of their life are influenced by different things. So they're conducting these experiments on their own. And this is what we are calling a self-experiment, where an individual is serving as their own treatment and control group. And the advantage of such an experimental design is essentially the results that we find are more applicable to a particular individual rather than a population, which is at the end of the day what we want when we are doing such user-centered design research. But when we are building tools to support such self-experimentation, we first need to understand what are the different types of questions that people have regarding their health and from the data they're collecting. So to explore this, we first turned to sort of two prior studies that we had conducted in the space, where Jessica Schroeder led the work on building a visualization platform for understanding relationship between different nutrients and the symptoms they were triggering in IBS population. And I led the work on building a platform for running such sort of self-experiments among the population and determining which particular food might be aggravating the symptoms of a particular individual. So we had collected qualitative data in these studies, which sort of hinted that there might be more to than answering this the basic question like, is this particular food triggering my IBS symptoms? So like I mentioned, in the prior studies, we only focused on like two particular questions. The first was by how much do my symptoms change when I consume the nutrient? And the second was how much of the nutrient is associated with increase or decrease in symptoms. But as we dove deeper in the qualitative interviews, we noticed that people had other questions, and particularly people had more questions once they answered a question that they were already seeking to collect data to answer for. So for example, when informed that a particular nutrient was correlated with a change in symptoms, patients often wanted to know the quantity of the symptom change. So take the example of patient 8, who was looking at the impact of caffeine on their abdominal pain and said, is being more awake worth potentially having stomachache, which matters more to me at that particular moment? So there's some sort of trade-off where the person is able to say, like, I'm willing to put up with this much amount of abdominal pain as long as it helps me stay up and do my work. And health providers were particularly interested in quantifying the differences because it influenced the advice that they might give out. So when examining a nutrient that had been found significant, one provider explained, I bet it's correlated, but clinically it doesn't make any difference. And that's what my interpretation is. So it also, the data that the patient is collecting is also helping the providers give them sort of more tailored or sort of personalized care at that point. And among the patients I mentioned, there was also a notion of progression where once they answered the initial question they had, they started following up with more and more detailed questions. And this is something that Alex will sort of cover in more detail in her talk, which is following me. And briefly going over what are the different types of questions that people have. So This is all based on the qualitative data that we had collected with the IBS population. But we wanted to figure out whether these questions are also broadly applicable outside of the IBS domain, and which is why we are sort of listing them as a sort of a generic set of relationships between the independent and dependent variable. So the first couple questions are the typical hypothesis testing question where Q1 focuses whether there is any effect at all between the independent and dependent variable, and Q2 sort of narrows it down to something which is more of a noticeable effect. Q3 is an interaction effect which focuses on scenarios in which there might be multiple independent variables affecting dependent variables, and Q4 is something that focuses on temporal effects. Q5 focuses on the threshold for an effect, and Q6 focuses on the varying effect. And both can be considered as a precursor to a cost-benefit analysis by helping a self-experimental trade-off how much of something they want against the symptoms they should expect. So something similar to the previous scenario of deciding where the line for trade-off between drinking caffeine versus abdominal pain is. And finally, the questions 7, 8, and 9 focus more on the predictive effects, where previous questions were accounting for differential relationships between the independent and dependent variables, versus, these ones are depending on what happens when there is a normal exposure, what happens there's an excess exposure, or what happens when there is no exposure at all. So these are sort of 9 broad categories we distilled down from the interviews. And then we created a survey in which we collected 78 responses. The participants wanted to investigate a range of scenarios. So from chronic illness, chronic pain, stress, anxiety, diet, sleep, fitness, and weight loss. So there was a range of sort of responses and what people wanted to collect data and answer questions about. And then the way we structured the survey was essentially get the independent and dependent variables from them and input them in the sentence, like what kind of relationship do you want to explore between these two? And what we found was like everyone found all the 9 categories to be useful in their own personal journeys. And most of the people had already answered the basic question of is there any effect at all or not? So this essentially validated that, okay, the 9 questions are useful. They are not something that was just unique to IBS. So at that point, we explored what are the strengths and weaknesses of different statistical approaches in helping people answer these questions. And the 3 approaches that we broadly looked into was null hypothesis testing, significance testing, which is a basic correlation in some sense. Then slightly different version of frequency statistic, which is not as common, was frequency estimation. And my understanding as a non-statistician is essentially this is Bayesian without any priors. And then finally, how useful is Bayesian estimation and prediction, which was something that Morgan was discussing in the previous talk. And the TLDR version of this is frequency statistics is able to answer some of the questions readily that people have, but there's a caveat there where, first of all, we are not directly answering the question. We usually convert it into a null hypothesis and then reject that null hypothesis. And then communicating that to a lay audience itself is a challenge. And the second thing is, because we are dealing with self-experiments, the amount of data that we have for each individual is quite low. And the way it works out is because of the small data set, the frequency statistics is often prone to being influenced by outliers or confounders or other factors. And although Bayesian analysis is able to answer all of these questions, there's a huge caveat where it depends on the accuracy of the prior knowledge. So there are situations in which we might have a sufficient prior knowledge to get a meaningful response, but there are other situations where we might need to actually collect our own prior knowledge or go with sort of a skeptical prior or optimistic prior or figure out how to deal with that. So it's not without its own challenges, but it's something that has at least the potential of answering all the questions. And finally, what does this all mean in terms of researchers or people who are building tools to support people across these various medical conditions? So the first is essentially, we first need to figure out how to elicit specific and measurable questions that people have about their own health. Unless we know what the person is trying to do, it's difficult for us to effectively support that. And of the 78 survey respondents, we had also asked them, like, what is the question that you're trying to answer before showing them any of the other things. And we saw that only 38 people responded with a question which was actually possibly answerable to an experiment. Most of the people had questions like, what kind of foods are safe to eat? that is not something we can sort of effectively help them with in a concrete manner. The second point is designing self-experiments based on questions people have rather than based on questions that we as researchers or designers feel are important. So in the system that I built, we are basically answering the question of like, does this particular food trigger my symptoms? That's the most basic question that the providers and experts who are working alongside us wanted to answer at the first step. But as soon as you answer that question, then you open this box of questions like, okay, is there a threshold? How much of this is tolerable versus how much of this, is there a sort of a latency effect or a temporal effect? There are all other questions which are now we are not able to answer because we are restricted by the data that we had already collected and also by the statistical framework that we're using. And oh, sorry, I'm already a minute over. And this last point I want to say is, although Bayesian analysis might be useful in answering these questions, there's a whole another challenge in how to effectively communicate that, because there's a big emphasis on communicating uncertainty there. And we know from our experiences, like even communicating basic bar charts can be difficult. So communicating densities and uncertainties is its own challenge, and exploring that and how to effectively counter that would be a useful direction for us to explore. With that, I would say the paper is available at this URL, and I can be contacted, and so can the other authors on this paper. And with that, I would move on to Alex.